Next, we have Debra Houry. She is the director of the National Center for Injury Prevention and Control at the Centers for Disease Control and Prevention. She leads research, innovative research and science-based programs to prevent injuries and violence and to reduce their consequences. And she'll be talking about the CDC guideline.
Well, good afternoon. And as Roger mentioned, I'm at the CDC, and so one of the reasons why I was here today is to talk about our experience developing the chronic pain guideline, but then also some of the activities that we're undergoing right now around acute pain and our updates. So this slide outlines the process for the guideline. I was new to government when I joined. This is one of the first key projects I was given. I don't think at the time I understood the significance of that project. And this was quick. For a government guideline. It took 18 months. So just to put it in perspective with all the different steps up here. And I'll go into a little bit more of how we use evidence reviews as well as public input, as I think that might help influence this group a bit too. So I think one of the reasons why we were able to be so efficient in this was because there was already a big systematic review that had been done. So we're able to really utilize that to kickstart our guideline. The AHRQ had this systematic review published in 2014. So what we did then was updated the evidence through 2015, really utilizing a few key questions to do that, including the effectiveness of long-term opioid therapy, harms and adverse events, as well as just really looking at some of the predictive instruments out there to influence clinical practice. So the evidence review criteria, we always try to follow the gold standards of the evidence that was out there, but I think as we've heard from this panel, sometimes there isn't the best evidence or types of gold standard studies that are out there. We utilized randomized controlled trials when they were available, as well as controlled observational studies. We did include some uncontrolled observational studies if patients have been on opioids for greater than a year and that had outcomes that reported abuse, misuse, or addiction as a primary outcome. Otherwise, we excluded these uncontrolled observational studies. We also did include studies of 3 months or longer when it came to non-opioid pharmacological therapy or non-pharmacological therapy, because we knew there were even fewer studies in that area, and we wanted to capture as many as we could. So we started out with 4,200 studies, and you see we only ended up with 39, but it doesn't really look as bad as that. We had many that when we started reviewing the abstracts and pulled the papers, it was the wrong study design, the wrong population. So we narrowed it down to these 39 to include in the review. I think as evidenced by the HRQ Clinical Evidence Review, a lot of the evidence was rated as low in quality, and that was something we wrestled with a lot when it came to talking about our guideline, because low in quality doesn't mean bad evidence or bad studies. A lot of the evidence around hand washing itself, would be low in quality. And so we would use examples like that, or people talk about the parachute, where there's like no evidence if you jump out of a parachute that or jump out of an airplane without a parachute, that's a bad thing. So we tried to really talk about that, but then we thought it was important to have that contextual review to put the clinical studies in perspective. So we did a contextual review around alternatives to long-term opioid therapy and epidemiology of opioid pain medication overdose to really help inform those recommendations. Because of the large volume of literature, as well as time and resource considerations, we focused largely on systematic reviews and clinical guidelines in this area. We did exclude studies outside the U.S., as well as pediatric studies, or studies that were already included in our clinical evidence review, because again, we wanted this to be something unique to inform the clinical evidence we had pulled. So once we had an initial draft, we started the process of getting input from the public. The first thing we did was we had a core expert group, which included some CDC staff, as well as professional societies, subject matter experts, as well as people from state agencies. They provided individual input. We then revised our guideline accordingly and really started down that long path that y'all saw on that second slide, to where we had federal partner engagement. We had stakeholder comments from over 20 different medical and professional organizations. Then we went through peer review, which is one of the required steps for CDC, to where we take that, all the different comments we're getting, and go through an outside peer review. And we had several different aspects of public engagement and comment. Early in the process, we had webinars to where people could give input. Are we on the right path? What do you think of the evidence? What do you think of the recommendations? And then after we had a near final draft, we published it in the Federal Register for public comment, and we set the CDC record for number of comments ever, 4,372. And we actually went through every single comment. We categorized them and made many revisions based on the public comment. We had over 100 specialty organizations and patient organizations that provided comments, and these were not single sentences. They were usually, multi-pages. And so very helpful, though, I think, to look at how guidelines might inform clinical practice. Then we had a Federal Advisory Committee work group that looked at what were the public comments we'd received, the revisions, as well as the guidelines we developed, and did it look like we'd really been responsive. After that, we published the guideline. So did that within 18 months. I think it's important to look at the credibility of our guideline development process. And an external group, the ECRI Institute, did an evaluation of our guideline. As you can see, overall, it did extremely well when you looked at things like literature search, public engagement, the evidence that we utilized. And I think it's because we took so many different opportunities to get different input and to use the evidence that was there and to then use the contextual support. Something else we did, too, with the guidelines is we had different tiers. So A would mean it would apply to all patients, but then B would be something about individual decision-making required, and we specifically use that one for things like urine drug screens, to where it might not be applicable for every patient, but that was really between the patient and the provider for that. After all that work, we did not want it to be a document that sat on a shelf, and so we really thought about how do we make this user-friendly. And I've heard many references to different types of providers. I'm an ER doc, and so I kept saying, we have to make it to where people can utilize it, and I appreciate all the pages and all the nuances in the guideline, but not everybody reads all 60-plus pages, and so, what do we need at people's fingertips? And so we had a checklist that we did in coordination with a tool, Gawande. We had an app for providers that helps calculate morphine milliequivalents, as well as how to do motivational interviewing with patients to really ask some of those questions. We also then developed clinical training for providers with free continuing education, have worked with different health systems about how to implement it, including developing integration into electronic health records and different prompts. And then finally, working when we can with different insurer and pharmacy benefit managers, particularly around the non-opioid and non-pharmacological treatments. So just to mention a few of the ongoing work we still have around this guideline. So last year, we developed a quality improvement and care coordination plan for implementing the guideline in health systems. We also have a number of projects and pilot sites implementing the guideline into EHRs using clinical decision support, taking some of the key recommendations from the guideline and just having those prompts that pop up while you're in real-time clinical practice. And then, as mentioned, we have a lot of online interactive training for healthcare providers. When we first were trying to work with different medical schools, I asked if it'd be easier for them to just develop their own curricula and have us provide technical assistance, and many wanted the curricula that they could then integrate. So we developed really patient case, not just talking heads type of curricula that people can utilize. So what are we doing now? What's on the horizon? So as part of our Improving Opioid Prescribing initiative, we're developing clinical tools. We are reviewing current guidelines that are out there, and this might sound familiar, looking at what are some of guidelines that have good evidence behind them. We plan to highlight those this summer with different clinical tools that people can utilize in clinical practice. We are also now doing a descriptive analysis of opioid prescribing rates for many different medical conditions, both acute and chronic. We have identified 40 conditions, and I mentioned to Robbie that when I actually get the list of clinical conditions, I'm happy to share that with this group. My understanding is about 20 are post-op. And then finally, We are looking to undertake a revision of our guideline. We said we would do that after about 5 years. And so currently, AHRQ is doing an acute pain review. That should be open for public comment in early 2020. And if there's enough evidence, we'll incorporate that in our updated guideline to further flesh out both the acute and chronic recommendations. And with that, I'll turn it back to Roger. Thank you.